She also has AI enabled to help with some note taking. So you will see a little notice on that as well. Oh, that's a fun fact, Emily. I didn't even know that. This is the first quote we used. Wow. I can't believe it's already been a year together. I don't know about you guys, but time goes by much faster as I get older. I don't care for it. All right, you can go ahead and advance to the next slide for me. Meeting logistics, we've got our names and our organization's names in the chat, what you're excited about for 2024. If you're not on camera, we encourage you to be on camera and spend some time with us face-to-face on a Friday, but it's absolutely not required. So just putting that out there. Again, we do record. We do have closed captioning and transcripts. So if that's something that you need, please let us know. All right. And I skipped ahead. Emily, if you want to advance to the next slide. I've already skipped past our icebreaker. What are we doing today? Welcoming 2024. I can't believe the end of the month is almost near. We'll do a quick pulse check on the managed care plan transition. We had 2 plans, as a reminder, that are exiting or exited the network as of 2024, January 1st. We have 4 plans that remain. So we'll do a quick check in there. We'll talk a little bit about some of the things that we've been working on in 2023 and status on an update on December's activity. We have a ton of community announcements and updates. The first of which is going to include a presentation by Heather Summers. Thank you, Heather, for being on deck first meeting of the year. We're really excited. She's going to be sharing some of the things that have been happening in the children and youth work group. So really excited to bring that to the group as well. And then we'll end with closing next steps and the plan, I think, for Q1. All right. Go ahead, Emily, to the next slide. And I can go through this if you want, or you can. Okay, so really quick, we're assuming that a good amount of folks are here. We've registered successfully. We have a new series for the new year. If you're not seeing some familiar faces in the room, let us know. We'll send an email out again, but we think that registration has been successful. We switched it to Zoom late last year, but again, we have the transition for 2024. Just a quick reminder, if these are for whatever reason not showing up on your calendar, it's because when you registered and got the email confirmation, you didn't select that additional add to calendar option. So that's the biggest change with regard to that. In-person meeting dates and locations. So we're finalizing some things right now. We've got some updates hot off the presses. But we will send out a save the date in the next couple of weeks for August 1st in person. So we'll share that with folks shortly. And then we will begin planning efforts for August. Office hours. So coffee chats are going away, so to speak, and being replaced by a more different name, but really it's somewhat the same in that they're office hours. So it's going to be an open block of time. We'll have some structure, but not a lot. They're meant for a space for folks to come together. If we're feeling like they're not adding enough value, then we'll do other things to kind of energize or maybe come to the table with specific topics that we're talking about on those office hours. Another important note, office hours are combined with the Contra Costa collaborative. So it's meant as a space for an engaged conversation and peer-to-peer conversation. We've combined those two collaboratives together because they're the two that we host. But the registration is open. So if you have other folks that you think might be interested in participating in something like that, let us know. Next office hours is February 8th. Specific instructions, screenshots. Okay, we're good with that. Everybody's here. Emily, you can go to the next slide for me, please. Updates, updates, updates. Okay, so really quick, wanted to do a pulse check on managed care plan transitions. I'm hearing from some folks just based on different meetings that have been occurring in the first few weeks of January. So we are collecting feedback. We've been trying to collect some feedback and share it with the managed care plans. I also met with them this week. But as you know, you all are going through this transition, my best guess is you'll be uncovering things that are working swimmingly and things that maybe still need to be ironed out. And as that's happening, you know, please let us know if there's a way that we can do any connecting or elevating. That's part of this collaborative as well. And, you know, it's not just January that will be the month of transition, recognizing that any type of transition to this magnitude is going to be something that kind of goes for several months, right? You're going to have the initial impact to your clients and to the people that you serve, and then there'll be administrative paperwork, obviously, and then claims adjudication. So as you're kind of going through that process, please feel free to share. You can send something directly to us, or you can share in the Slack channel. And like I said, we'll continue to do the best job that we can to collect all of that information and make sure that we share it with the managed care plans as needed. I'm going to stop talking for a quick second. I know we're a bigger group, but we're not a huge group today. So if anybody, I didn't monitor the chat. I haven't been looking at it, Emily, so flagging that if something came through. But if anybody wants to come off of mic, if you have some information to share or any of that, this is the time to do it. We have some time just to kind of do this pulse check. How are folks feeling about the transition?
Hey, Denise, can you hear me? It's Claudia with CHG.
Hey, Claudia. Awesome. Happy Friday.
Happy Friday indeed. Just a quick update from our part. You know, we received transition files from the exiting health plans, and we engaged all of our providers in the network, and even potentially some that were possibly outside of the network, just to ensure a more organic approach. Did a lot of dotting of our I's and crossing our T's to ensure that members were appropriately authorized for services, and providers can share their feedback as well, but just working very closely with them. But all authorizations are good to go and providers are rendering services.
Thank you so much for that, Claudia. I don't mind a little dead air, but I want to make sure that we have some space if folks want to come off of mute. If there's any sharing, you can also enter information in the chat or reach out to us directly.
Denise, this is Heather. I did want to mention as far as the transition goes and the plans are aware, Rady Children's Hospital had reached out to us. There have been some issues with the transition in that the medical home wasn't necessarily adhered to, and there were some, we had some pediatricians who had brought up that they had received letters and their patients were being assigned elsewhere. And we were able to connect Rady's with DHCS, and they were also able to work with the plans And I think they're on their way to addressing all of those issues. And then just yesterday, San Ysidro Health Center said several of their patients have been assigned externally. And so we're working to connect them the same way. So I think it's just with a large number of individuals going through a transition, and there is a bit of difference depending, from my understanding, on the information that was coming from DHCS didn't necessarily contain the primary care medical home office. So depending on what information was exchanged, that could have been a root cause. But the plans have been extraordinarily responsive, and DHCS has been as well. And we've just been connecting folks as issues have arose.
Thank you so much for sharing that, Heather. Yeah, we are hearing that those files weren't necessarily in that ideal state. So there had been some issues even before the transition to the new year, and even after in some of those file shares. Anything else anyone wants to elevate? All right, well, we're moving along. I'm going to hand things over to Ryan really quick.
Yes. Hello, everyone. So just wanted to talk a little bit about kind of our tests of change. So last month during the meeting, Emily, if you want to go to the next slide, we did a little activity where we asked questions around what would you like us to start, stop, and continue? And so in thinking about the responses that we got, rather than sort of going through everyone here, they are in the appendix. So there is, you can see what everyone shared in the appendix, but really wanted to go through just a couple of the themes that started to emerge from those. And so the biggest thing that came up around what you would like us to start doing in 2024 was really more focused stakeholder and community engagement strategies. And so those are some things that we had begun to sort of map out at the end of last year, but are really focusing on now. So that was very timely feedback. You know, we recognize the importance of making sure that we have the right players at the table and making sure that we're involving, you know, the right people. We also want to make sure that we're engaging with community members and people with lived experience as these decisions are being made, so that they are part of the process as well, so that it's not just kind of a top-down approach. I mean, we really want to make sure that we have, you know, the right folks at the table. So we are working on that, and we'll be kind of building out that strategy, and, you know, can certainly share that, but that's kind of where we are with that. So that is in progress as we speak. Things to leave in 2023, surveys or impersonal surveys and questions not getting answered. And so I know that, you know, there's definitely survey fatigue is real. No one loves doing them. I think it's, so we want to make sure that we're intentional about any types of information that we need to collect, and making sure that it's relevant, and that we're explaining kind of the intention behind it, so that it's not just one more thing on your list to do. And as far as unanswered questions, I think that was more around specific, you know, questions about policy related questions, and some of the bigger challenges that you might be facing that, while they may not be CPI specific, they have impacts on your work. And so getting more guidance in certain areas from the state or from other entities. So really want to make sure that we're being supportive and helping to get some of those questions answered. And then things to keep doing, the provider spotlights were shared along with any successes and best practices. So, it's easy to talk about what's not working, but it's also important for us to make space to talk about what is working, and what you're experiencing so that you can share that with others and highlight, your programs and services, but also, sharing that with others can potentially, offer new opportunities for working together and collaborating, in the work that you're doing. Identifying opportunities for data integration was another big one. I know there's the work group that is currently going, and so that's a big topic of discussion. Obviously across the state, but data is a big element, and so keep working on opportunities to do that better, and building efficiencies within the referral authorization process. And so again, those are sort of things that are being worked on, and I think the universal referral form for ECM. And so again, great feedback from the group around things that you liked and didn't like. And so again, there's a more specific details are in the appendix from the activity that we did last month. So is there anything that anyone wants to add or any questions about that before we jump to the next step?
I was just gonna joke and say, and here's a survey for you to answer. No. Anyway, go ahead.
We didn't think about that. That would have been fun. Okay, Emily, you can go to the next one. So we have sent out best practices playbook that we've been working on. So I think it went out earlier in the week on our Slack channel. We also had a small subgroup of the larger CPI that came together and looked at sort of what we had initially, and so tried to factor in a lot of that feedback. There may be some things that we didn't quite get in there, but the idea behind this playbook is that it's really something that can serve as a tool for sharing your successes, things that you found that have worked in your programs, so that can be shared with other providers, whether or not they offer the same services. So some of the practices in there may be specific to to certain populations of focus, for example, but the idea is that they're transferable across organizations. And so, we want to highlight again what's working for you so that we can share that across the collaborative and strengthen the network of services. And so our hope is that you will take a little bit of time and sort of go through it with keeping in mind that it is the first version. So we certainly recognize that there are areas that we want to improve upon, but getting feedback around sort of the information that's in there, what it looks like, how it's presented, are there other items to include that would be helpful? Certainly if you're looking at it and you think, hey, I have something that I would like to share, let us know, because we would be happy to chat with you and get more information so that can be included. This is a living document. So again, we'll add new practices as we go. And what we also want to do is, as you learn about a new practice, and if it's something that you decide you want to start doing in your program, we would love to know that, and we would love to find out how that's going. So with the idea that if it's a practice that is refined and tested across different organizations and populations, then we could start to call that a best practice because it's kind of been out there and tested more times. So we want this to be an iterative tool or resource. We certainly want this to be something that's useful for you and your team. So, again, any feedback that you'd be willing to share, good, bad, or ugly, is certainly welcome. So again, that's in our Slack channel, and we can send it out again as well. But so just wanted to highlight that. And I think there's not any questions. I think it's you, Denise.
Yeah, thanks for that, Ryan. So I joked with Ryan yesterday. I said it can be kind of like the Hunger Games. So we're calling these best practices because they're information that we've taken from the start of our first in person in September and identified as best practice, but also because it's been announced from peers in the field. So I said Hunger Games because it's kind of like, well, let's see if we can break some of these best practices. Are they really best practices, like Ryan was saying, or are there things that we can improve on? So excited to see what this document and playbook looks like at the end of 2024 after a full year of iteration. So let us know, and we can talk with you one-on-one, or like Ryan said, the Slack channel, or any feedback you have is what we're looking for. And I'm going to hand things over to Heather first. We're going to talk community announcements and updates. So I have a slew of updates, dates, webinar dates, DHCS updates, some things that we'll start to talk about more in February. But before I rattle all of those off, we're going to talk about the Children and Youth Work Group, and Heather's going to share some updates with this group from that work group. Now, in effect for what, Heather, maybe 6 months now? Maybe a little more.
It's about 7 months. Yeah, you're right on track.
Time flies. Okay, Emily is going to bring that document up shortly for you, Heather, and we'll be able to. Perfect. Thank you so much, Emily. And we'll hand things over to you now, Heather.
Great, thank you. I'm Heather Summers, Deputy Director with the County of San Diego, and today I'm going to talk with you a bit about our Healthy San Diego Child and Youth Ad Hoc Work Group. I'll share a bit about the purpose of why we formed, what areas that we've been focusing on, and then I've got a section to share a success story and a case scenario for how we could perhaps collaborate better, and to also get your feedback as well. So why don't we go to the next slide? So we started, as Denise referenced, roughly about 7 months ago. Initially, we were meeting actually twice a month, and it was just, I think in November that we switched to monthly. And then part of the need arose out of a conversation from Healthy San Diego to get ready and prepare for our child and youth population of focus. I am one of the co-chairs for that group, along with Kim Fritz from Blue Shield Promise Health Plan. And we've got the representatives on the screen that currently make up that group. What we've decided to do as far as our approach really is to look at that child and youth component, and then start to look at the subpopulation areas that fall within child and youth. And I can get more into that. Next slide. Just to share a few statistics and grounding information. In San Diego County, Medi-Cal provides health insurance for over 1 million people in San Diego County. That number can ebb or flow a bit. We're in the midst of redetermination and a lot of enrollment increases. But roughly that equates to 1 in 3 Medi-Cal beneficiaries here in San Diego County. We are the 5th largest county in the United States, and we have the 2nd largest Medi-Cal population in California. As of September 2023, For children and youth under age 21, we had about 383,000 individuals, children enrolled in Medi-Cal. Part of what we've started to do in our work group is to start to look at estimates of children and youth that may be eligible for enhanced care management. And I did just want to caution this a bit. What is a bit challenging about the population of focus, and when you see the number of 21,820 on there, this was information that we had gathered with the assistance of the plans, a snapshot in time from summer and fall of last year, when we started meeting. When we're looking at that number, there could be a lot of duplication in there as well. So we're talking about children and youth that may be experiencing homelessness, families that may be experiencing homelessness. We're looking at hospital visits or emergency room department utilization, children or youth that might have behavioral health disorder or substance use disorder. This also includes children in our CCS, our California Children's Services Program, in child welfare, and children transitioning out from incarceration. So it can be a bit difficult to actually a set number when you're looking across all of that variety of populations. But that's been one area that we at least wanted to get an initial kind of ballpark number for how many children and families may be eligible for enhanced care management. Next slide. I had mentioned a bit earlier the subpopulations, and when we look across the board at children and youth, there are several areas that they can really cross over, and I mentioned this a bit earlier. So you'll see across the board, one or more children similar to adults could have multiple factors or come under multiple categories for that population of focus. And you'll see our most recent one that started actually in January of this month was the birth equity population of focus. Also mention for the children and youth component as well, what has come up from several of the providers from our ad hoc group is really looking at, there may be multiple children under the age of 21 in the home. So they could be providing, care coordination or enhanced care management or community supports to multiple children in the home. And in addition, they may also be providing some type of support to the adults in the home. So there's a lot of the entire family potentially could be receiving some type of enhanced care management or community supports, which has its pluses or minuses. I will say at the start of the discussion with our ad hoc group, some of our providers were calling families, and they were a bit concerned, thinking Child Welfare Services was calling and that there was a mandate for services. Many of the providers who have been participating in our ad hoc group have come up with their own kind of in-reach activities, as well as their own kind of introduction to the service, and have started to discuss that this is really as a benefit and an additional service. And we've also heard from our plan partners as they start to describe the service that they're explaining the same. But that's something to keep in mind as we get further along for that outreach and marketing and really explaining the service. It's really important. We're seeing a lot of adults and parents and grandparents, rightfully so, maybe a little reticent at first in accepting that enhanced care management referral. Next slide. So as we started to talk about our children and youth focus areas, we identified a total of 6 areas. We wanted to look at data by each subpopulation. and come up with some quantifiable number and try and estimate. I mentioned that earlier. We also wanted to look at the specific needs of the population. So for children and families, are there unique areas as far as medical needs, behavioral needs, and social needs? We also, for the third category is really look at that, again, that population, subpopulation. Out of the existing contractors for enhanced care management community supports, are there enough contractors to meet the needs of each of the subpopulations? Another area that we wanted to discuss was communication with the medical home or their primary care provider or their doctor, any clinical providers, anyone on the enhanced care management team, and the managed Medi-Cal plans. So one of the case scenarios we'll actually discuss specifically number 4 when we get down to it. And then our 5th area was really looking at the youth and children population and providers that had demonstrated experience working with children and youth and with various subpopulations. And then any additional considerations that needed to take into account for our specific subpopulations. And then the last area was wanting to look at approvals, referrals, and transitions of care. So authorizations, contractor assignment, enrollment, etc. So that was our charge when we started. Let's head on over to the next slide. So I did want to share and explain a bit more. We've covered this, so you'll just see on the screen, just as a reminder, what the children and youth population of focus can entail. So it's just a different version than earlier when I started talking about the subpopulations. Why don't we go to the next slide, and I'll give a few examples of different types of provider areas that might be good referral sources and maybe areas that everyone is working with when they're coordinating the needs for the children and families. So when we're talking about children with serious mental health or substance use disorder needs, those provider types could include coordination with school-based clinics or behavioral health providers, our public health and social service programs, our community-based organizations serving children and families with social needs, county behavioral health. When we talk about our children and youth enrolled with California Children's Services, we have specific CCS providers that are really medical providers that are specialized in working with children that have specific medical needs. It could also include specialty care centers, pediatric acute care hospitals, and as an example as well for CCS, Brady Children's Hospital and the County Public Health Services Department work together quite a bit coordinating CCS children's needs. For children and youth at risk for avoidable hospitalization or ED use, got the school-based clinics, medical providers as well. And then for children and youth involved in child welfare, you've got your community-based organizations, public health and social service programs, First Five, Help Me Grow, WIC, Black Infant Health, etc. So a lot of different focus of provider types, and each unique to their own. We go to the next slide. So I did want to share from a document from last November, is that the Department of Healthcare Services did publish a children and youth spotlight that gives some good examples and some resources. One of the areas that they had really suggested that we look at is presumptive authorization and really looking at trusted providers that can help streamline access for children and youth who can automatically qualify for enhanced care management, and also look at a process to screen enhanced care management members for needs for community supports and refer onward when needed. And next, I'm going to share a success story. And this one comes from I wanted to share a success story specifically from the County of San Diego in looking at the impact of enhanced care management on children and youth. And in this success story is going to come from California Children's Services. So the county provides medical case management services, including physical and occupational therapy. California Children's Services, also known as CCS, offers care to children with chronic, disabling, or life-threatening conditions, and children enrolled in CCS have both medical and social needs beyond what our county program can offer. This is an example. I'm using an alias, but a child served by CCS, who we will call Jane, recently moved with her family to a new home and school district. Jane received enhanced care management through her Medi-Cal plan. And similar to all teens, Jane was really struggling with the move, adjusting to a new home and high school. Jane has type 1 diabetes, and to fit in at school, was not taking proper care of herself. Jane's pediatrician and medical care team reviewed her care and suggested enhanced care management to assist with her overall care coordination and social supports so that Jane could manage her health condition. The CCS case manager referred Jane to ECM, and she was assigned a lead care manager. The ECM lead care manager worked with her parents to assist with transportation needs. They also provided patient education on the importance of diabetes control and assisted Jane in how to manage her blood sugar. This allowed Jane to take better care of herself and her health. The lead care manager connected Jane with an in-home behavioral health therapist to assist with the stressors of moving and changing schools. The lead care manager also worked with the family to obtain her medical supplies needed to monitor and treat her diabetes. Jane and her family and the lead care manager developed trust quickly, and when Jane identified a potentially serious medical complication, she reached out to her lead care manager, who immediately connected them to the medical team and for medical care. This quick response avoided a potential hospital stay and assisted Jane and her family with better tools to manage her health and well-being. So that's a success story, one of those areas on number 4 for coordination for the medical home that I wanted to share with this group. And in the next slide, I'm going to talk a bit about a case scenario. This actually came from one of the members of our ad hoc child and youth group. And as we go through this, perhaps just thinking about, how can we best coordinate care with family systems between the doctor, our managed care plans, and our enhanced care management services. So we often have many people involved in our children and youth lives, and just thinking about how we can best kind of coordinate or what questions we could ask or share. So I'm going to share a story about who I'm calling Gus. And Gus may sound like an 80-year-old. In this case, I've given him an alias and he's 12. All right, so Gus actually lives with his grandparents. He was born premature and had early developmental and behavioral difficulties from maternal drug use during pregnancy. Gus received early start services through Regional Center, and due to ongoing parental substance use and domestic violence, Gus was placed with his grandparents, who are now his guardians, who he hasn't seen in a long while. At age 6, Gus was diagnosed with ADHD and has been managed by the same doctor for the last 6 years. School has gone relatively well, but recently he was started on medication for anxiety and panic attacks, and he's gone to the emergency room for them as well. His doctor, who also manages his ADHD medication, has been increasing the dose of medication to assist with his panic attacks. He is currently receiving mental health therapy through a local community-based provider. And after his last emergency room visit, he was referred to enhanced care management because he was having a behavioral crisis and because of his multiple emergency room visits by the mental health team at the hospital. His doctor knows him well at his medical home and is also caring for his younger brother and sister. At a recent ADHD follow-up with his doctor, the grandmother stated that now he has another doctor who wrote a prescription to change his medications, and grandma couldn't get the ADHD medication refilled. Grandma is not sure which medications to give him, although grandma decided to stick with what his long-term doctor was giving him. Grandma reported that the child was bullied at school, which led to the last emergency room visit, and that she also received a call from the insurance to set up appointments with another therapist. Gus has always been thin, although he eats well and does play sports. He was born early as a preemie. His doctor reports that he's met steady on the growth chart, and they've been tracking his labs and nutrition since he was young. Grandmother also stated that she was anticipating and that there was a suggestion for a referral to a nutritionist because when he went to his visit, they thought that he was malnourished, and his doctor has referred him in the past to a nutrition clinic. And grandma's not so concerned about his weight at this point. However, she did report that sometimes he doesn't eat well at school because of his ADHD medication. So in this scenario, just wanted to consider how could we best coordinate, and this was a real scenario from one of our ad hoc members. And if you've got ideas, feel free to raise your hand or put them in the chat or reach out to me, or if you have an interest in joining our ad hoc group. But definitely want to consider, how we can best coordinate between the doctor, the insurance, and the enhanced care management team. One of the suggestions from the providers is how do we, could the enhanced care manager be helpful in calling the school to see how the child is eating at school? Is there anything from the care plan that could be shared with the provider office? I know in this case, we had a non-specialty community-based mental health provider providing care to this individual and to Gus. Are there any best practices out there on how we coordinate and share with our doctors and primary care providers? I know what has come up with a few contractors for enhanced care management out of our ad hoc group. They have mentioned that they've accompanied the children in the past and families to medical visits, but just wanted to get your thoughts on that case scenario.
I'll give folks a second to respond, Heather, but I'm curious if there's no responses, what ideas you might have or could share just based on the work group conversations thus far and the services that the county provides.
Sure. So one of the providers who helped shape this particular case scenario just wanted to make sure that we're all asking, who is your doctor, or where does your child receive their vaccines? Do they see someone regularly? And then anytime that we're talking about medication management as well, there is a regular primary care provider. really encouraging some type of coordination of care or connection to have a discussion around medications being prescribed. Another recommendation was, is there some type of support or program at school that could support or complement the mental health therapy? He's having some panic attacks. And just thinking about how we can best share case plans or coordinate services with the provider. And Janet, you were great. Yeah, I think a multidisciplinary care team to come up with a plan, I think is a fantastic idea as well. I think we've got a lot of complicated systems and services coming into play, especially with a young person that's going in and out of the emergency room. And then you've got the schools involved, the primary care provider, enhanced care manager. And it may be, as we get into more of these cases, that perhaps it is a good case for some type of multidisciplinary team to address and come together.
Thinking also about San Diego's sort of infrastructure. I know we talk a lot about data and data sharing and data exchange and some transitions as it relates to client care. Anything sort of come to mind? I would say just based on San Diego's infrastructure.
Well, I mean, we do have the health information exchange, so I know that the pediatricians or doctors can access certain information from the emergency room department to view that. You know, as far as the referrals for services, I know that we're building and having discussions with CIE and talking about closed loop referrals. I know that there is still some information gaps that we can't view necessarily electronically. So it may be a consent and some type of additional information that needs to be shared via old-fashioned fax or another way. And I see that Cammie has her hand raised.
Yeah, thanks, Heather. That is an issue I think that we contend with at the Community Information Exchange that HIE does not have because our CIE is an opt-in model. So what it requires is our community as a whole to look at where is the entry point of the system of care for our families, and then where is the best opportunity to offer the families an option for consenting information in so that we can have that information. We do have a couple of pilots with the county, and we also have some technology integrations happening with Epic and Rades and other folks. But at the end of the day, it is that consent issue because CIE is an opt-in model.
Yeah, consent's always a doozy when we talk about kiddos and informed consent and legal guardian.
Yeah, other than the information exchange, which is always a little sticky and takes a lot of time, I think it's, you know, are there opportunities for a multidisciplinary team meeting, or it could enhance care management provider accompany the family to the next, you know, pediatric visit as appropriate. Those are about the two ideas and some that we've brainstormed, but are open to others as well.
This is Cammie again. I'll just add that I think it's because of the population of focus, but we are having more and more conversations with the school districts, looking at what's a good point of entry for the system of care. And never more than now have school districts been coming and willing to go through the bureaucracy about talking about sharing data. And it is scary and it's multifaceted and layered for youth. But I think that progress is happening, and I think people are interested in looking at all points of care and entry points.
And that's a good point, Cammie, because I think that's so important. at the schools, whether it's a family resource center or the nursing staff or the teachers. There's a lot of touch points at the district for reaching children and families. And so that could be another kind of touch point to provide support as well.
And I'll just elevate, Heather, as you're reading, Nancy shared a good sort of question comment in the chat around impact on the school districts with, these sorts of collaboration in terms of capacity, thinking about impact, frontline staff, and how schools process something similar, a 504 plan. There's a few others that sounds, somewhat appropriate for this care scenario.
Absolutely. All right. Well, thank you for letting me presenting Gus. Oh, and there may be one other comment as well. Good. Okay. And Janet, this is good too. So you've going to talk about trainings as well. And I know so the health centers can benefit from specific training on community supports and resources. And then also for children and foster youth. And I will say there's some unique areas specific for our children and foster youth. And actually, thanks to Janet, and we had opened it up to our children and youth work group as well. We had actually brought in county council that work for our child family well-being department to talk about some of the unique areas working with children in foster care. But there are many challenges and opportunities when we talk about our children and youth. And Janet, I'll add to that list. Some of what has come up is foster care system, different diagnoses, more information needed around learning disabilities, community support resources, IDD and testing. So there's a lot of needs around working with children and youth. And some might even be, how do we help educate the parents around community supports or managing a specific, whether it's a medical or developmental or behavioral health diagnosis, or how do I get testing for my child? And how do I really connect them for care? So in Gus's case earlier, he received early start services in regional center. Even when you talk about the school district system of care, whether it's a 504 plan or working with regional center or even getting specific diagnosis through speech, occupational or physical therapy, it is not the easiest system to navigate. So if there's other kind of training areas that come to mind, please let me know. And then Denise, maybe this is an area too. We could even look at, is there something broader from Healthy San Diego or even the PATH Collaborative to really focus on these areas? I'm starting to, I think we're going to end up with a good running list. Another area that's challenging and also gives opportunities is around marketing and outreach. How do we really increase the reach and the promotion of services? And specific for children and youth, as I mentioned before, how do we approach it so that families see it as a benefit and positive and are less worried and concerned that it might be connected with child family or child welfare services? And then how can we continue to think about how to best coordinate referrals and services between the doctor, the family, and the care coordinator? And then also on here, connections to schools. I put through family resource centers. This is not exhaustive. There's many ways to connect to the schools as far as care coordination. And then another big challenge that I'll mention at the county is we've got a lot of our children in foster care currently fee for service. And so there's been lots of discussions, actually discussions just started and in the midst about children who are on fee-for-service and why is that in San Diego County. And typically the state in each county has had the option for foster care to decide whether they're enrolling children in fee-for-service, also known as straight Medi-Cal, versus enrollment in managed Medi-Cal. But as the system has started to change, there's much more of a holistic kind of care package that can be provided for children who are enrolled in managed Medi-Cal. So that is an area that our child family well-being is discussing and is also brought to our ad hoc, and I know are discussing it as a department. But that could absolutely add to the children and youth number that I shared earlier. In really increasing and putting more of a focus on how we care and coordinate for our foster care children. So much more to come. Thank you for letting me talk a little bit about our children and youth services. And feel free to reach out to me if you have any questions, concerns, ideas. Emily will send out the deck. It also has my contact information on it and open to ideas. And thanks so much.
Heather, thank you so much for sharing. I know that, we think about, just awareness campaigns, community awareness campaigns, general public, and then training and resources that are available, or if not yet available, how can we bring that to the community? So we can talk more too. I don't know if Calium Academy is a thing for 2024, but if so, we're happy to collaborate in any way, shape, or form. But yeah, it's almost too much, there's so much information and there's so much opportunity, but also recognizing that we have, workforce turnover. And so what we can do to look at curriculum in the community and how we can kind of build that up so that folks can, based on resources available or staff turnover, really participate in this, this education opportunity is to kind of really get in and get to the direct service or direct care that everybody's providing. So really appreciate it. You guys have been doing an amazing job, and I really thank you so much for sharing with the rest of the CPI and for being first up on the docket in January.
Thank you for having me.
So the next 30 is probably won't even be 30 minutes, but I'm gonna rattle off a bunch of other updates. I think that this is probably just the start of some of the topics, but we will start here and then we can keep the conversation going. So obviously the additional populations of focus for January 1st. I just want to elevate that there is a DHCS webinar coming up. It is scheduled for February 2nd. We included the registration here. The deck will also be available. In addition to that change, Emily, if you want to advance one more slide. I think we have some additional changes and things that are sort of happening or bubbling up or taking everybody's priority over the next couple of weeks. And so for those of you that are applying, cited round 3, the deadline for that is February 15th. We've included some information here. DHCS is also hosting some additional webinars, office hours. So we'll share that information with you all as well. The other thing, just a critical call out. So round 3 applicants, there's some information in the application about specifically how what you're applying for can or will, or what you believe will impact different gaps in the community. And so what I mean by gaps is gaps in managed care provider network or associated with a corrective action plan. Outside of JI, Justice Involved, there isn't anything listed yet from DHCS, and we've talked briefly with the managed care plans as far as gaps. that are current. So most of the CAPS corrective action plans are from prior years. However, I did talk with the managed care plans, and any managed care plan on the line, you're welcome to chime in. That yesterday, gosh, yeah, it was just yesterday. Outside of JI, the housing trifecta, housing navigation, it, is still a gap in networks. So flagging those two things. But I know we have the managed care plans here. If folks have questions, or if you're applying for cited round 3 and you need to talk with a managed care plan, you obviously have them here, but also I'm sure that there's direct channels. Happy to navigate or connect any of those conversations. So let us know. Anybody, and I guess you don't have to share that you're applying, so not to put you on the spot, but if you want to send us a direct message, or if you need any assistance in getting some of that information, let us know. Other call out, TA Marketplace. I think we have some additional information on that, as well as an upcoming webinar. I've also just been informed that they're going to have a virtual vendor fair, so there'll be more information there on the TA Marketplace and how to participate in some of those upcoming sessions. Okay, you can go ahead, Emily, to the next slide. I think these are the dates. I know one of them is today. There's just too much going on all the time. We try to do the best we can to work around all of the other state, regional, and community events. It doesn't always happen, but we do the best that we can to have that work for you all, given that you can't be in 6 different places at once. So we are flagging these dates on our calendars, but the other one that we have is February 29th, and that is for the TA Marketplace webinar. So in addition to these different meetings, we have this one here for the TA Marketplace. Thanks, Emily. And Emily's also shared some additional information, resources in the chat. So flagging a few of those. So lots going on. DHCS just published January 1st, some new codes, HCPCS codes. So we have that listing, and we'll share that as a, I think probably you already shared it in the chat in Slack. But I have heard from some folks too, wouldn't it be great if we had some additional information sessions on those, billing for those codes. So if managed care plans are hosting any training sessions, calling that out, please let me know, and we can elevate that and share that with the rest of the group. If anybody's aware of any of those events, please share that with the rest of the group. And if no events exist, we would be happy to try and host something or come together with folks to get something to happen. Perfect. To get something to happen for those HCPCS codes. I don't, Nancy, know about round 4. I haven't heard anything just yet, but I'll ask some folks on staff. There's a few intrepid folks who have been sort of, ear to the ground on different aspects of CalAIM, now Medi-Cal transformation. So if they know of something, we can share that with folks after today's session. Not DHCS related, but state of California related, data exchange framework. So for those of you who are considering the data exchange framework or are signing the DSA, the data sharing agreement for the data exchange framework. I mean, we have so many acronyms. Okay, so if you've already signed, but you're not a required signatory, the runway is longer for you to comply with those policies and procedures. The biggest first date is going to be the end of this month, which is next Wednesday. where required signatories are supposed to be implementing those policies and procedures. Remember, the data exchange framework is not let's connect to this statewide hub or this single point in California. It's meant to be the rules of the road to increase data sharing electronically across the state. Ryan, thanks so much for that additional information. I think, Ryan, don't we have also an update on the PHM? So I want to hand things over to you for a quick update on the PHM, but then also flagging a few dates here that we have for Path JI. So even though there's been some finalization, there is a way that you can reach out by emailing that email address that's on this slide for consideration of additional funding opportunities. Okay, Ryan, I'll hand things over to you for a PHM.
All
update.
right. Thank you. So just a real quick couple minutes around population health management, also known as PHM. So that is basically an initiative that DHCS has in place to ensure that Medi-Cal members, all Medi-Cal members, have access to the comprehensive set of services that is based on their needs and the preferences that they might have. And so it really addresses more of the whole person care kind of approach to serving Medi-Cal members. And so ECM and community support sort of fall under that umbrella of PHM. And so there was a new policy guide that was just released, or an updated policy guide that was released just this week around PHM. But I wanted to sort of highlight the section around transition care services. And so that is an area where it's really focused on helping people make transitions from like hospitals or acute care settings, recuperative care, sobering centers, into another type of care. And so it was originally designed more for higher risk members, but they've also, as of January, implemented another tier, I guess, for lower risk members, which is essentially everyone else, all the other Medi-Cal members. And so just a quick kind of summary of those two categories. So the higher risk members would be those that are entering complex care management or ECM, maybe long-term support services. It also includes pregnant individuals who were hospitalized during their pregnancy or within the 12 months after. And there, there's other categories as well. Those are just some of the initial ones. And I do want to point out that you ECM case managers, if you're working with someone who falls into this transition care services area, then essentially the ECM lead care manager would be the care manager helping that member navigate those services. So it would be making sure that they're connected to whatever resources that they might need as they're being discharged from one setting and going into a different one. And so there's a lot of overlap with what you would do as an ECM care manager and what you would do as part of this transition care services. But so it wouldn't be an additional person that they would have to work with. And so that is more for the kind of the higher risk. But for the lower risk members, so everyone else, they don't have to have a dedicated care manager, but the managed care plans have, there are numbers that the members can call for assistance. So, if they're discharged, they have a 30-day window that they can reach out and get guidance on if they have specific questions or issues, but not making them go through the same intensity of services if it's not something that they need. So that's a newer element that's just went into place in January for the rest of the Medi-Cal population. So just wanted to highlight those. DHCS had a webinar this week about it, and so we wanted to share that with you because there was definitely a lot of overlap in population served. So
Yeah, thank you. Thank you so much, Ryan. I don't know how you all keep track of all of the webinars. There's already enough going on in San Diego, and I think just even in like the last week to 2 weeks, there's just a ton of webinars. Ryan's going to one, I'm going to another one, another member of the team's going to another one, and then we're all kind of trying to come together to share what we can. But if we miss something that you guys are aware of, feel free to share. We're happy to elevate for you, or happy to push something out in that Slack channel. We try to put everything under news and announcements that we learn about, including if there are new grants that we learn about that might be applicable for folks, different webinars, events, learnings, etc. So we'll continue to sort of use that Slack channel to broadcast that information. Does anybody have any additional questions for Ryan, PHM, other things that are sort of changing for the new year? Okay, we're almost done, folks. We've got 15 minutes. I swear I won't take all of them. So Emily, if you want to go to the next slide for me, or the next after the next slide, the slide after next. All right, we'll wrap it up with what's going on. What are we doing? Who's on first? Best practice playbook. If you haven't already looked at it, please do share your feedback with Ryan. I think there's a couple of things that have changed in the new year that we need to already update on that playbook. So we're continuing to work on that as things evolve. If you think that you've got a best practice that you want to share, we've got Ryan's email here. He's absolutely willing to meet with you, talk about that best practice, and package it in a way that we can share it with the rest of the collaborative. February is fast approaching. Happy leap year. I don't know if anybody's a leap year baby. My grandmother is a leap year baby, and we had a big joke when she turned officially 21 that I took her out and got her a cocktail. So and she's 90, she'll be 92. Yeah. So anyways, yeah, don't ask me to do math end of the day on a Friday. Okay, February, we've asked Christopher to join us. Christopher is from San Diego County. I've attended a few meetings under Healthy San Diego where he presented different data similar to some of the information that Heather shared. But he really has an amazing dashboard that we wanted to share with the rest of this group. Everybody's coming in to CalAIM, Medi-Cal Transformation, Enhanced Care Management, Community Support Services from different places at different times. And data has been a critical theme in San Diego. We have a data standardization work group. We'll continue to ask them to give updates either in the monthly meeting or give us an update that we can share via Slack or send out to folks. We're looking at how can we get in content and information to you all in an easy way. Can we save you emails? What would that look like? We're also looking at ways that we can update our website so that it's not so difficult if you miss a registration, or if we stand up or host a new event, you can see the calendar of events all at once. And get access to quickly different resources and materials. So stay tuned for that as well. Save the date. We'll send you out a nice Canva save the date announcement once we have everything locked down. It will most likely be either the last week in April for our normally scheduled, or the week before that. So what is that? The 19th or the whatever, one of those 2 Fridays. So we're getting everything solidified now, and we will let you know once all that's been scheduled, and then we'll begin planning. Office hours, February 8th. Remember, these are combined office hours. They're not structured conversations. We'll come with updates if we have them. This is combined with Contra Costa's CPI. Test of change. So just a reminder on all of the things that we're working on. We are working on that best practice playbook. We're working on the enhanced care management universal referral form. We're also through the JI work group in San Diego, working on some presumptive authorization. CalAIM Academy, we're going to try and make that happen for 2024, whatever we can do to add additional curriculum that's valuable to you all. Let us know if you have topics that you think that would benefit the group. So happy to talk about that more. Data standardization work group is continuing. They're actually working on a few different things right now. In addition to that, we have a directory. So in San Diego, we have directories on each of the managed care plan websites of contracted enhanced care management and community supports providers. But don't forget, we have a single central directory through the San Diego CIE. And so that is there for folks. If you go there and you notice that your enhanced care management organization or community support organization's information is inaccurate, there's a process that you can follow to update your information. If you don't feel like doing the work, reach out to us. We can work with the CIE. The idea is that this is an updated and helpful document. So anything we can do to support the CIE and support you all, I think is work worth doing. I think that's enough for us to work on, but that's sort of what we have in the hopper, if you will, for our work over the next couple of months. We're also working on building out that event calendar. And so where we can for agenda topics and spotlights for different community supports, enhanced care management providers, let us know. Emily put that in the chat earlier in today's presentation, but also please feel free to reach out to us directly if there's something that you think that the group would benefit for us talking about in more detail. Okay, I swear that's it. 9 minutes. We're done. End of story. And I'll check the chat. Emily, is there anything that we need to elevate before we give everybody 8 minutes back in their day? Yes.
Besides
Lynn.
Lynn's, did you see Lynn's comment?
Yes, Lynn, there is.
You guys didn't have to elevate it. I was, excuse me, I was just putting it there as I know, and it's more specific to the JI population. You had mentioned the presumptive eligibility, and so that just got me thinking. And then you gave the update on the CalAIM Medi-Cal transformation matrix as kind of a source. And so I was just wondering, is there any plans? Because I don't think, and if it's already done, I apologize. I haven't been in there in a few days, but is there any plans to say like what provider is serving what population of focus?
So Cami, I'll just answer quickly for you. I know that they are looking at that, and you can correct me if I'm wrong, Cami. But I know that Joe over at CIE has been looking at ways to incorporate that information into that directory. Part of that will require us to have that information so that they can upload it. Cami, if you want to add any additional detail.
Yeah, and just for clarification for everyone, it's on the 211 San Diego website. So I know we often confuse 211 and CIE, but it's 211. It's kind of the landing page for 211. What we would love, we know that this information is already collected by each of the health plans for your contracted providers. If there's any changes to populations of focus, if we can aggregate how we get that information from a single source, rather than having to reach out on a continual basis to every contracted provider, that would be great. But that's the long answer. The short answer is yes, we're working on it. It would greatly expand the matrix that we currently have, but we're really looking at how do we get this from a single source and do it in a way that's not taxing the folks who are already providing that information directly up to the managed care plans. But it is in the works.
Thank you so much for that. For those who want to drop, feel free. I hope you have a great rest of your Friday. Janet, I see your comment as well regarding the DHCS code. I don't know if there's any managed care plans still on the line who want to answer that. If not, I'll take that as an action item and see if they're not having any training yet, what we can do to connect with them and provide that training back to the CPI.